Thanks, Paula. Okay, so here we all are gathered from across what we refer to as Canada, from different places all across the country, across Turtle Island. We're people who live on treaty lands and unceded territories. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms comes from a history of colonialism and its enduring practices, institutions, and ways of thinking. So colonialism isn't something that was just in the past, it's with us today, and we must commit to working in ways that reshape these institutions and practices and ways of thinking to repair harms, prevent future harms, and work towards a more inclusive and just future. And I'd love to encourage you to put in the chat your name and where you're from, and if you do know about where whose land that it is that you're living on, then please do share that as well. It's interesting to learn about all the different regions of Canada, where we're all coming from, and the names of these different lands that we don't always identify or acknowledge. We have a certificate of attendance for you if this interests you, if it's helpful for you to have a certificate of attendance. What we'll do is we'll pop a link in the chat, probably about halfway through, and you can click on that link and fill out a little form that appears and submit that form, and you'll get an email that's from Certifium, and in there will be a certificate like this. And it'll say it'll have your name, and then for attending the workshop, wound care, with the date. So if that's helpful to you, please look for that link in our chat. Yeah. So very quickly about the National Safer Supply Community Practice. We're funded by Health Canada, Substance Use and Addiction Program. We're a collaboration with London Intercommunity Health Centre, Alliance for Healthier Communities, and the Canadian Association of People Who Use Drugs. And our focus is really on scaling up a medical model of safer supply, but we're also very supportive of the development of a whole wide range of models, including non-medical models. And our focus is really on knowledge exchange, capacity building, connecting, learning, growing, and scaling up safer supply. And we've got an amazing website. So if you want to join the community of practice, check out our website. There's a join there. But in addition to just being able to join, you can also find a big resource library in there and all kinds of other info and events. So, and then we're on social media, all these different social media, Twitter, Instagram, and Facebook. Yeah. If anybody has any questions, let us know. Our website has a bunch of previous webinars and things like that up on it. You'll see there's a whole bunch of things that we've done already, including our expert panel of people who use drugs. And coming up this month, we've got, at the end of April, we've got a pharmacist roundtable. So if you want to hear what safer supply is like from a pharmacist perspective, or if you have a pharmacy that you think should learn more about safer supply, then refer them to us and this workshop that we're doing on April 28th. And we have a prescriber consultation line. So if you have a doctor that you think should be doing safer supply, or a nurse practitioner who should be doing safer supply, let them know that if they need support and help to prescribe, that the National Safer Supply Community Practice is able to provide that support. All right, enough from me. I'm really happy to turn it over to Sunny and Erin. I'll let you introduce yourself, Sunny and Erin, and thanks everybody for joining us today. It's great to have you here. Just making sure you know you're on mute too, Erin. Oh, there you go. You're already on.
I do, and I just have to go back to the start. There we go. So yeah, to start, Sunny and I both live and work in Toronto, which is Treaty 13 territory, and subject to the Dish with One Spoon Wampum Belt Covenant. So that is where we are coming from. I work with South Riverdale Community Health Center. And I'm really happy to be doing this session because, as Rebecca mentioned, acknowledging that it's not just nurses and doctors doing wound care. Well, actually, doctors do very little wound care, but it's not just nurses doing wound care. We know that people are taking care of each other in community and in lots of different spaces. So I think it's good to not be gatekeepers of any knowledge, but to share that knowledge and increase our capacity all around, everyone, kind of regardless of what our background is, so that we can better care for ourselves and the people that we care about. So a little bit about us. I'm Erin, I'm a nurse. I work at the Moss Park Consumption and Treatment Service / safe injection site. And I've been working with the Moss Park community since 2017. I was one of the volunteers with the unsanctioned site when it opened. And I stuck with it when it became a sanctioned site that's now administered by South Riverdale Community Health Center. As a human and as a nurse, I love people who use drugs. And so that's been the focus of my work. But I also really love wound care. I also work at a wound care clinic on a casual basis. So that's a little bit about me. And I'm really happy to have my colleague and friend Sunny joining me today. Sunny, do you want to tell people a little bit about yourself?
Hi, I'm Sunny. I'm glad to be here, working alongside Erin. It's always a pleasure working with Erin. We've done a bunch of different projects this year, and it's always been amazing. Yeah, I just right now just thinking if I should wear a hat or not. Sorry. I worked with her at Moss Park since 2019. As an overdose response worker with lived experience, and have like gained the knowledge to become a proper functioning member of society who can work and can use if they need to use their whatever, what have you. But yeah, my sparks taught me a lot about how much I care for the people that we serve and their health and safety. That's all.
Yeah, Sunny and I have a shared passion around safer injection technique, and so that's where we sort of started collaborating. And so I thought that kind of like married nicely with skin and wound care. So what we're going to talk about today, so these are sort of the objectives. We're going to talk about wounds and infections, why they happen, and Sunny's going to go into safer injection technique a bit more. And then we're going to talk about basic principles of wound care. We're going to define chronic versus acute wounds, talk about assessing, cleansing, and dressing wounds, and about ways to support people with wounds. And then at the end, I will share some tools and resources that might be helpful for folks who want to learn more. And I think also want to leave lots of room for discussion. Love to hear what everybody is seeing, what the challenges have been, what the successes have been. Yeah, want to have some space for some some learning for us as well about what folks are doing in other settings. Okay, so like here's just some sciencey stuff, some physiology stuff. wounds and infections. So what causes an infection? Basically, you have a pathogen. So that could be like a bacteria, a virus, or a fungus sometimes as well. Any of those things. And then you have the host, which is the human being. Those two things come together. The pathogen gets into the host, and then it grows in the host. So it proliferates in the host, and then that's an infection. And an infection can happen in the skin. It can happen anywhere in the body. It can happen in your teeth. It can happen in your joints. It can happen in your heart. It can happen in your kidneys. It can happen in your urinary tract. So wherever that bacteria gets and wherever it grows, that's where your infection is. So another thing that has a big impact on infections is what they call host factors. So that's basically things that relate to the human being who has had the pathogen introduced into their body. So there's a lot of things that affect how well we're able to fight off infection on our own. And a lot of that has to do with our own immune systems. So, you know, there are certain illnesses or conditions that can make someone have a weaker immune system. So something like HIV that can make someone's immune system weaker, but other comorbidities as well, like people with diabetes are considered immunocompromised, so have kind of weaker immune systems. But also, if you're not getting adequate nutrition, which we know is really common with the folks that we work with, there's a lot of food insecurity that will have an effect on the immune system. And also exhaustion is a huge one. Like if you don't have a safe place to sleep, if you've been up for days, that's also going to be hard on your immune system. So all of those things can just make it harder for our own bodies to fight off those pathogens, those bacteria, fungus, viruses, if they've been introduced into our system. And different kinds of bacteria, viruses, and funguses, they have places that they like to go and proliferate in the body. So some bugs you'll see more commonly in some sites than in other sites. And then Sunny, can you speak to the last bullet there?
The last bullet there is not all skin and wound infections are caused by drugs and or injecting. So if someone's a drug user, if they come in with a wound, it's not automatically from drug use, and that's just a stigma that's put on the healthcare system, and it usually brushes people away from getting the care they need, because that infection was because of rusty nail or something, you know what I mean? So they're not getting the treatment that they deserve or they are warranted, and because the healthcare system automatically goes to drug-seeking behavior, which wasn't the case most times. And we shouldn't treat all skin and wound infections as a drug-related incident, and treat it case-by-case value.
Yeah, and I think that's such an important point, because I think, like, I've seen it a lot as a nurse in a lot of different settings where the assumption is made that, like, oh, this problem was caused by injecting drugs, and the assumption is made, and then people work from that assumption. And then I think about all the things that are maybe being missed that someone like really needs medical assistance with, that are just being missed or dismissed. because healthcare workers still have so much stigma around people who, in particular, use injection drugs. So thank you for bringing
Yeah, I personally face a lot of times when I would meet up regularly with my MRP, like most responsible practitioner, because of my drug use, would automatically go straight to that. So if I have a problem with something, the first thing would be, oh, did you use this? Did you do that? And it had nothing to do with what I was coming to them about, right? And it's very demeaning, and it's very it's not how you want to feel when you go tell a person something very personal and private and confidential like that. And yeah, like, who do you turn to when you have a problem and they're telling you it's because of this, and it's not, and then there's nothing, like, they're the top people to deal with. So where do you go from there? Right?
Yeah, so absolutely, not all skin and wound infections are caused by injecting. And we still want to minimize the risk of that being a cause of an infection. And there are lots of things that we can do to support each other and support community. So I just pulled this picture off the internet because I think it's kind of funny. So like it's a picture of, I guess, someone taking blood. And the reason I think it's funny is because the person is not wearing gloves, which is not what not what they teach us in nursing school. So if someone's doing phlebotomy on you, or if they're taking blood from you, they should probably be wearing gloves. But the point I also wanted to make with this particular photo is that we all have bacteria on our skin, like at all times. It's just a normal thing. In particular, something called Staph aureus. That's like a really common bacteria that we all just like have. Like if you swabbed my skin, you swabbed like anyone's skin, you're likely to find some Staph aureus. Like it's just so common. And it's not harmful unless it gets past our skin and into our tissues or into our bloodstream, right? So this is kind of why like cleaning the skin with an alcohol swab before injecting is so important, because what you don't want to have happen is for there to be a bacteria like Staph aureus, for example, that gets pushed into the tissue or pushed into the vein to circulate in your body, because that's when it causes problems. So if you get a bacteria into your tissues, you might get cellulitis, a skin infection, you might get an abscess, but that bacteria can also just like circulate in your bloodstream. It can land in a joint, it can land in your heart, and cause endocarditis. It can land in your spinal cord and cause an abscess in the spinal cord. So once that bacteria gets pushed into a vein, like the veins are just kind of like a super highway for the bacteria to kind of go anywhere. And then, sometimes that happens, it ends up in your bloodstream and your body is able to fight it off, and it doesn't do anything, it's fine. And then sometimes, and again, it's those host factors, sometimes it lands somewhere and it proliferates, it grows, and it causes a bigger problem. So all of these pieces are connected. Yeah, so to the next slide. just in terms of talking about some of the basic principles of wound care in general, one really important thing is that whatever care plan you have for addressing a wound or addressing an infection is that it has to be like person-centered care. It has to work for the person who has the wound. And so like in the medical world, they teach us about like compliance, like is the patient complying with the care plan? And I think, you know, we can all see why that's really problematic. And so in wound care, we talk about adherence to the care plan. And adherence is really about like, is the care plan good? Does it work for the person who has the wound? Because for example, like if your wound dressing is covering up the only like spot or the only other spot that a person can, you know, use to access a vein, then that's not going to be like a good care plan. Sunny, I don't know if you have anything else to say about that. We talked a little bit about this earlier.
Person-centered care is a good way to, oh, sorry, I just screwed. Person-centered care is a good way of describing it, because not every wound is or infection is the same, and people's bodies are autonomous, and they shouldn't have to follow these exact rules for them to be better, right? If someone's a user, one of the rules might be do not use drugs. They're gonna use drugs. So it's for the healthcare provider and for the client to come up with a plan that works for both of them and gets to the solution rather than authoritative figure telling you gotta do X, Y, Z or else you're done. You know what I mean? So yeah, like definitely like working together as a team is a good way. And you gotta treating the cause instead of treating the system. When you get a drug addicted client, you're not trying to unleash all either hatred or stigma or preconceived thoughts that you had on drug users on that person, right? Because they're a singular person, they're not the whole group of drug users, right? So you gotta treat the actual person and their needs.
Yeah, and I think like it makes me think of an example where there was one person who had a chronic wound, and I'll talk more about acute versus chronic wounds. But she had a wound that was slow to heal, and she kept getting dressing changes from nurses that kept like really just like covering up the wound in a way that she couldn't access that area, which she needed to access in order to inject. So we actually like figured out a way to have like one edge of the dressing that was sort of easier to remove and then reapply so that it worked for her, so that she could have the wound covered most of the time, but she could also like peel it back and access the site when she needed to. And that's like person-centered. Like she was able to we were able to adhere to that care plan because it worked for her different needs. And I think we also have to think about things like where are people living? Like if people don't have access to like if people are living in a tent, then they might need more frequent dressing changes, or they may need us to actually give them supplies to change their own dressings, because it's hard to keep a dressing clean if you're, you know, in the park or in a tent. And, you know, thinking about like those pieces, like the logistics of how someone's actually going to keep their dressing intact, and how what the conditions might be for them to be able to safely do a dressing change. And just to go back to the treat the cause, treat the system thing, I mean, I think, you know, treating the cause is never like, don't do drugs. Like that's not harm reduction. That's not what we do. But treat the cause might look like does this person have enough, like, do they have adequate nutrition? Is there some way that we can support them to have adequate nutrition? Because just like getting like a good amount of protein in your diet is really going to help with wound healing. So if someone is, you know, malnourished, then treating the cause means like nourishing them, and that's really going to help their own bodies to heal. And the treat the system thing, like I always think about, and I think some you've seen this too, where it's like someone's in hospital and maybe they've had an operation or something, and they need to have wound care in the community. The way the system is designed is that they'll send wound care orders to what they call like LIN clinics. And they'll be like, okay, you have to go to this address 3 times a week to get your dressing changed. And oh, by the way, when you get there, you're probably going to have to wait for a long time to actually see somebody. But they will have the dressing orders and they will have the dressing supplies. And that's how you're going to have your wound dressed. And that doesn't work for a lot of people. Like if the clinic isn't close, that can be a barrier. And having people wait, like people are busy trying to like just
survive,
live their lives. Yeah, survive. So you can't ask somebody to be waiting for an hour to get a dressing changed. And then you also don't know if the providers at the LIN clinic like have capacity around harm reduction so that they're actually going to treat the person in like a humane manner, right? So that treat the system kind of stuff, like I think there's like room for advocacy to say, like don't send those wound care orders to the LIN clinic. Send them to our nurse at the CTS, at the safe injection site, at the drop-in, whatever, wherever that person is going, like frequently, where you see them regularly, where they're accessing services, like, you know, doing that piece and saying, no, actually send those dressing orders to us and we can take care of it here. Because the system doesn't work for people. So sometimes we need to get in there and advocate for it to work for people. And then like the nitty gritty of local wound care is pretty straightforward. You need to cleanse the wound. You want to keep your wound clean. Debridement is sort of, that can range from just kind of like a bit more of an aggressive cleansing to sometimes like in a specialty clinic, a nurse or doctor will use like kind of sharp tools to actually like sort of scrape the edge of the wound. And the reason they do this is all that dead gunk that ends up in a wound can actually slow down wound healing. So you want to try to keep as much of that out of the wound as possible. And then you also want to have bacterial balance. So every wound's going to have some bacteria in it, like all of our skin has bacteria on it. But you want to make sure that there's not so much bacteria that it's causing more inflammation, causing local infection, and then maybe even causing what we call systemic infection, or like a deeper infection. So there's a lot of different like products that you can put on wounds that help to manage the bacterial balance. And I'll talk a little bit more about those later on in the presentation. But then the third piece is moisture balance. So I know a lot of people feel like, or it's kind of like that old, you know, that old idea that like just let it dry out, let the wound dry out. Like that's, that'll make it heal faster. And sometimes, yeah, if it's a little wound and it's just like, that's fine. But really, if you're looking at a wound that's having a harder time healing, you ideally want a moist wound healing environment. So that means you want the wound covered, and you want there to be not too much moisture on the wound, but not too little either. You don't want it drying out. You want to kind of have that like Goldilocks effect of like just right amount of moisture for optimal wound healing.
Yeah. And that's why it's good to have. That's why it's good to have these wound supplies like sent to like the OPSs and the CTSs, where they see the clients like for a long period of time, and they have the nurses that are equipped to take care of those wounds. Right? So yeah, just going to add that.
And Sunny, can you talk a little bit more about when I made this slide in the treat the cause, I was also thinking about ways that like safer injection practices can support folks who have skin and wound infections.
I'm kind of drawing a blank here, but I do remember that when you're wrapping up when you wrap up your arm or whatever, a lot of folks, what they end up doing, if that's the spot that they end up injecting in, that's their spot, they're gonna whether or not a doctor says don't do it, don't open up that bandage, they're gonna open it up and they're gonna inject in there. So finding a way to have that covered, and like having all their bases covered. They should also teach the client how to inject in a different spot and rotate their arms and spend the time with the client, like looking for another vein and like slow, like it takes time, but like slowly teaching them where else they could go for the time being while your arm is being healed, So yeah, like no matter what, like if I have a spot, I'm gonna use that spot, and then it doesn't matter, like because they need that immediate what's it called, hit, right? Rather than stumbling around and what's it called, not being able to hit themselves, right? Which will cause more frustration, and they end up ripping off their band-aid. Then say they're not in the CTS or whatever, they're outside. You don't have the bandage on. You don't have the wound care happening again. So until the next day or something. So they're shit out of luck, and then it gets worse.
And I think this is like speaks to the importance of like how much we need the regulations to change to allow for workers to assist with injection, because that would help, right? Like if folks don't have to inject into tissue that's already inflamed, that's already infected, because they have somebody else who can help them to find a different injection site to assist them with injection. Like I know for all of us, like it seems like a no-brainer, but we still don't have that change to the regulations that would allow for like peer assisted or nurse assisted injection. And I really think that's like it would really help people out.
And in Toronto, I know this is more so peer assisted, you also have to sign a contract that makes the CHC not liable for any cause of death or anything like that, which like makes it scary someone wanting to help their friend, but now, oh, if my friend overdoses and dies and like in an ambulance and there or whatever, I'm the one being sued or charged or whatever. So you're putting all the onus on someone that you're asking to help another client, right? And just because they're not able to, or not able to, they don't want to, they're not allowed to um, intervene themselves, right? So it's kind of it's kind of sense to me that like the people that have the least uh, um, the least they're low on the totem pole of like where the social economic status is, and they're the ones that are facing the most liability and helping in that form of healthcare, right? And yeah, from personal experience, I would walk into an injection room and it would be like I can't even spend like 10, 15, 20 minutes like by myself as soon as I walk in because I'm getting called all over the place to hit this person, hit that person, hit this person, hit that person, right? And there's and I've gotten used to doing that because I've gotten.
Yeah, and I think that's a really good point about liability and the risk that we expect different people to take on based on who they are. Like, I think nurses like have a lot of liability protection in our practice. And like a nurse could cause a bloodstream infection or cause a skin infection from poor injection practice. But we are all as a community trying to have those good practices, cleaning the skin before injecting. And I just really think we need to move forward on helping people to rotate sites, because sometimes folks do need that assistance, especially if they're trying to heal.
Yeah.
And I think just being mindful of time, like I think supporting people to go to medical appointments or to go to the Emerge if they need to go to the Emerge, like I think that goes such a long way for I don't know if it treats the system, but it certainly like addresses the system head on. And I really think people get treated differently in tertiary care or in primary care if they know that somebody else is watching. So that's us, that's, friends, it's workers, community members, like people get treated better in those like medical encounters when the medical professional knows that someone's watching, that there's a witness to how they're treating that person. So I think that is also so important to like reduce stigma and to help advocate with people.
Yeah.
And then that like if ongoing wound care needs to happen, finding safe places for that care and that monitoring in the community. And that might be a formal setting where it's done by a nurse, but that can absolutely also be at home or at, in community. I just want to get back to the science a little bit and talk a little bit about the phases of wound healing. So this is kind of like what you learn in like Wound Care 101. So the first phase of wound healing is hemostasis. That's the immediate response, is the body will stop bleeding. And that's hemostasis. That's literally what it means. It's like stop bleeding. And then for the first, from then until about 4 days, you have your inflammation phase. And I think we generally know what those signs of inflammation are, right? It's like swelling, sometimes it's redness as well, of like kind of local inflammation. And inflammation does not necessarily mean that infection is happening. And that's like that thing that they always tell you about, like if you miss a shot, you know, putting a warm compress on it, that's to like try to minimize the inflammation, let the inflammation phase do its thing, but not move to an infection phase. And then from 4 to 21 days is proliferation. And that's when the body and the immune system is doing all of its pieces to try to start the healing process. And then maturation can take up to 2 years. Maturation, that's like wound closure. And we generally don't say healing, we say wound closure, because anywhere where you've had a wound, you're more likely to have it like there is always the possibility of having the skin open up again. But that can take up to 2 years for like the skin to like regain its full kind of like tensile strength. And all of this sort of, I know, so my aunt was the first one who showed me this slide, and I thought she was out of her mind with this one, but it's really grown on me. And you don't like, all of these bits and pieces aren't that important, but I guess she had a student, like a wound care student, whose husband was like an engineer of some kind. And together they made this image, which kind of shows you all of the different pieces that are involved in healing of a wound. And it's a lot, like there's a lot going on in the body in order for a wound to heal or to close. And if you have like a problem with any kind of one of the steps, if like something, or if you get stuck in one step and can't get out of it, like all of these things are going to affect the final outcome. So I will just let everybody like appreciate how wild this particular slide is for one more second. Because I think then it's important to talk about the fact that there's sort of like largely two different kinds of wounds that we see. So some wounds are acute wounds, and that's the majority of wounds that we'll see in like a safe injection site kind of setting. And these are wounds where there's like the integrity of any tissue is compromised for any reason. So it could be because of an injection, but it could also be because of a fall or a surgical procedure, or because of an infectious disease or some other underlying condition. And acute wounds will move through the sort of phases of wound healing in a predictable manner. So like, for example, surgical sites, like that's like a perfect example of an acute wound. And if you've just had surgery, you absolutely need to use sterile technique to clean and dress that wound in the first, few days after surgery. But there's a difference between sterile technique and clean technique. And mostly what we're doing in the community is not sterile technique. We're doing clean technique, because the wounds that we have and that we're dealing with in the community have already been exposed to the world, and they're not as high risk as like a fresh surgical wound. So those are kind of like different things. But something we also see in the community is chronic wounds. And so that's a wound that fails to progress through an orderly and timely sequence of repair, or wounds that pass through the repair process without restoring anatomic and functional results. So I think we also see a lot of chronic wounds in the community. And these are wounds, chronic wounds can have a lot of kind of underlying factors associated with them. And they can be healable, they can be maintenance. Some of them won't heal without some major other factors changing as well. And some of them are non-healable, for example, like wounds associated with, a palliative cancer. But I think like one example that we see a lot in the community are and I'm wondering, I'm sure people have seen this, kind of like lower leg wounds, like wounds below the knee that are kind of like people get them, they close, then they open up again, they close, they open up again, and they're just like really slow to heal. And that's a really common type of chronic wound that's associated with venous damage, with vein damage, actually. So that could be because somebody's injecting in the veins in their lower leg, but it could also just be because, you know, maybe they've been a smoker for 40 years. That could cause some strain on the veins of the lower legs, or because they have a job where they have to stand for long periods of time. There's lots of different reasons why, as we get older, or depending on different factors, lower leg wounds are going to be slower to heal. Because as the veins get weaker in the legs, as they, you know, are damaged, what happens is there starts to be more swelling. They become leaky. Then there's swelling in the lower legs, and then it's harder to heal because of that extra fluid in the leg. So what you'll see sometimes is a nurse or a doctor suggesting that the person wear compression, which is basically just like a tight sock. And there's different kinds of assessments that need to be done in order to apply serious compression, because it can have some like negative effects. Like it's kind of complicated, and you really should have like a nurse practitioner or a physician weighing in on that. But for a lot of folks with those chronic lower leg wounds, what's actually going to help them heal is compression, which is that tight sock. But then you also have to think about, are they accessing the veins in their legs for injecting? And then so how do you make that compression work in the context of also needing to access that site? I'm sorry, I hope this science-y part isn't too boring. But I did want to move on to kind of assessing, cleansing, and dressing a wound, because I think these are all things that like all of us can be doing. And for any wound, when you're assessing it, you want to be thinking about the location of the wound, the size, how much gunk is coming out of it, and what's the color of the gunk. Because if the gunk is kind of clear, okay, yeah, you still want to manage the gunk. But if the gunk is like pus, like white and opaque, that's actually a sign that there's like an infection there, and the infection needs to be managed. But things like the borders of the wound, are they attached, or is there kind of, does the wound continue like below the kind of like the rim of the wound? Is there tunneling? Like how deep does the wound go? And then you're also looking for edema and erythema. And erythema is kind of the word for, you know, redness. And I think a picture is worth 1,000 words. So this particular picture is someone with cellulitis. And I'm sure most of us have seen cellulitis. And this particular person, you can really see the redness that's a sign, but you have to think, like not everybody's skin is the same, right? So that erythema is going to look different on different skin tones. So for someone with darker skin, you might not get the redness, but you will still see like the shiny kind of tight skin. And that is also a sign of cellulitis, of a skin infection in like the first couple layers of the skin. And for those kinds of infections, you actually do need oral antibiotics. You just do. And you know, only a prescriber can prescribe antibiotics, but just so folks are aware, kind of Septra, Keflex, and doxycycline are the most common antibiotics that will be used to treat a cellulitis. And the reason, I don't know if people can also see like these, I don't know why I'm pointing, I'm just pointing at my own screen. Can you see my cursor? Is my cursor visible? Okay, so these lines, that's pen that we've actually used to kind of outline the redness. And that's like a really smart thing to do if you think you're starting to see a cellulitis, is to outline the erythematous skin, or the, you know, the shiny part of the skin, the swollen part of the skin, to outline it with pen, because then you can see like in 12 hours how much has that erythema extended past the pen line, and that will kind of give you an idea of whether the infection is progressing or if it's getting better. So that's like a trick that I would say anytime you're worried about that, like get a pen out and outline it. And then I wanted to talk a little bit about this tool that we use in wound care. We use it a lot at the wound care clinic that I work at. And it's this like really dorky mnemonic. It's called Nerds and Stonies. But it basically helps you to decide if an infection is sort of superficial, because again, there's bacteria in every wound. So sometimes you get like a little bit of superficial infection, or whether the wound is telling you that there's actually deeper infection and that you need to be like, dude, okay, we have to go to emerge, or we have to go to your nurse practitioner. Like we need to get some like antibiotics on board. So the nerds part is if a wound is being slow to heal. Oh, and I think Sunny's just going to be switching to a different, but that's okay. I'm going to talk about this for a little bit. So go ahead, Sunny. He's just going to switch to his phone. So if a wound is kind of being slow to heal, if there's an increase in the exudate, which is like the gunk coming out of the wound, if it's getting kind of red and friable is like the medical word we use, but if it's like easy to bleed, if there's more gunk in the wound, and if there's like more smell, if you have those, that can be a sign of sort of a superficial infection there. And that's a situation in which you might want to have a topical antimicrobial. So I think the most common one that we see in the community is betadine, like that brown liquid. So that's a good topical antimicrobial, and it comes in different forms. So it comes in like an impregnated gauze. So it just looks like a little mesh that's kind of moist, like Vaseline, that also has betadine in it. And then there's other types of topical antimicrobials as well. But for something that's just having these signs, then you can try the topical first. But if you also have one of the Stonies signs, so if the wound is getting bigger, if it's getting, if the temperature is increasing, and you can't always tell by feeling, but sometimes you can. Like if I have a wound on this arm and someone touches not the wound, but like touches like the wound or the skin around the wound, and it's hot compared with the opposing limb where the skin is intact, like temperature is definitely a sign of deeper infection. And if the wound is deep, and especially if it's deep near a joint, like you'll see them often around knuckles where there's like a wound and it's right near a knuckle and it's kind of probing down. You have to wonder if the wound is deep enough that it's kind of hitting bone. And if it's hitting bone, then absolutely you're going to need antibiotics, because bones can also become infected. And that's a much more serious infection. And again, you always want to look at exudate. Is there more exudate? Is it stinkier? Is it more purulent? So is it like pussier, like opaque, white? And then you also want to look at that erythema and edema. So if that redness, swelling, taut, shiny skin, if that's increasing, those are the signs that there's maybe a deeper infection and you want to treat systemically. And by systemically, I mean antibiotics that you take by mouth, or depending, sometimes also IV antibiotics, which I know can be a barrier for people who use drugs, because there's a lot of reticence to put in PICC lines if it's going to need to be a long course of antibiotics, or sometimes they'll want people to stay in hospital to complete a course of IV antibiotics that are kind of not a central line, but just a peripheral one. But this is a good little mnemonic. If you're looking at something and you're thinking, is that infected? Is it not? Is it like a little infection that could be treated topically? Or is this like, dude, we gotta go get some help with this? Oh, Rebecca, yes.
Hi, there was a question earlier about people who don't have good veins and getting IV care. What kind of, like, how do they manage that for antibiotics and things like that? Oh, Erin, you're on mute. I thought you were thinking.
Sorry.
No, that's okay.
So if someone has veins that are difficult to access, and I know people get poked so many times when they're in hospital, but you can always ask for like interventional radiology or ultrasound guided insertion of like a peripheral IV. That's always an option, like in every major hospital. Like you can ask for that if you're just getting poked too many times. So there are tools available to folks working in a hospital to place an IV line, even if someone's veins are a bit more difficult to access. And like the average nurse, and I think a lot of people don't realize this, but like nurses, we don't get taught in school really how to do venipuncture. So whether a nurse is good at, you know, getting blood or putting in an IV really like has everything to do with how much practice they have. And like, that's it. Because a lot of nurses like aren't good at it at all. So you can ask for like, oh, can we get the interventional radiologist, or can we get someone from the IV team? Like they tend to have better skills. Because yeah, that's definitely not a fun situation, and people get poked a lot of times and it's not comfortable. Does that I hope that addresses the question.
I think the question was a little bit more specific around resources within Toronto, but I think that's a really great tip for everybody to know that they have the right to ask for that.
Yeah, I would say, sorry, I keep going. I would say that like certain clinics are better, phlebotomy clinics, that's for blood taking. I don't know about like Rosedale is in the neighborhood that I work in, and they have a lot of very, very skilled phlebotomists and lab technicians. So I would say that's a resource that we utilize and make referrals to there. And I'm sure, you know, there's clinics that are, or there's places that are great, and there's other places that are not so great, like everywhere.
Thanks, Erin.
What was the question specifically again?
Andre was asking about resources for people who struggle with their veins. I'm trying to find the questions in the chat.
Sorry.
Or Andre, if you wanted to speak up.
Yeah, just so basically I was an IV user for quite some time. I'm no longer like using intravenously, but I have a bunch of like scar tissue and collapsed veins, and basically anytime I go to give blood or go for a procedure that requires some kind of IV work or intervention, I don't know how you want to call it, but they basically can't really find a vein. It's very difficult. Like when I've been given blood, they literally like had to like prick my finger and like, you know, pump, like, you know, let it drop into like a vial. And yeah, it's really scary because, you know, going for like, you know, certain surgeries or certain, you know, medical situations, it's like there was a colonoscopy where basically, you know, they weren't able to put me under, even though I told them beforehand. Like, they just generally also don't take you really seriously. They're like, always like, oh no, we can get it, we can get it. And I'm like, no, you're not. And then it's only like when the actual kind of procedure happens that they realize, oh shit, this is going to be pretty tough. And yeah, so I've heard of the ultrasound. Some places, from my experience, some places have it and some places don't. They like, but yeah, if you're in a hospital, I guess they would have it. But a lot of times, well, like when I had the colonoscopy, it wasn't at an actual hospital.
Mhm.
But yeah, that was basically my question. Thank you.
Well, yeah, like I can speak to that as well. You like when you become an IV user, you know your body more than anyone else. So having a nurse that has done X amount of injections in their life has no like comparison to how many times you could hit yourself, right? So helping them guiding them would be a good way to help them get your vein. Also, yeah, like after your scar, after a while, your scar tissue does heal, and your veins do come back, and they're able to get them again. But if you're an active user, yeah, it is hard. So yeah, like for me, I just find it best to guide the nurse or the doctor or whoever it is taking the blood and letting them know where a good spot would be and where
Mhm.
I think it's dead.
And
Sorry. Oh, sorry to interrupt for 1 second.
Mhm.
Not to question the knowledge being shared, but I haven't used intravenously for about 5 years, and
Yeah.
my veins aren't coming back. Like, the scars are there, like it's like hard tissue, and the veins are not coming back. So like, I guess would the only option left be like deep veins, like that would be found through ultrasound, or I don't know.
Yeah, no, like I personally thought that it would be impossible for a nurse to find a vein on me. But if the nurse is good enough, sorry about that. If the nurse is good enough, they're able to find a vein faster than you can. Right? When I went to go to the hospital like a couple months ago, I thought it would be impossible. I was in and out of there in 5 minutes. Right? And so it just depends on the experience of the medical professional.
Yeah, and I would just add, like, I mean, everybody's body's different, right? So, yeah, sometimes scar tissue, it's with you, right? For life or for a long time. And I just like any nurses that are on this session, like, I hope you're hearing really clearly that people know their bodies best. So if someone tells you where a possible site is to get venipuncture, listen to them. I've learned this lesson the hard way, but like, let me tell you, like, if someone says no, go here, like, that's the first place I'm gonna go, because people do know their bodies best. And yeah, so there's like, I mean, PICC lines are always an option, right? And it's like a central line, so it's like an IV, but it actually goes, and they usually put it into like your brachial, like the vein in your upper arm, and the lumen of that one actually goes kind of like right to your heart. So often people will have a PICC line put in if they need a longer course of antibiotics, or if they're just needing longer treatment in general for whatever. It could be IV fluids. But I think like the situation you're describing sounds like it was like difficult, and I'm sorry. It doesn't sound like it was a good experience if they weren't able to actually administer anesthetic. Yeah, I think, yeah, I'm sorry for that experience.
Well,
Erin.
thanks for listening. Thank you.
Mm-hmm.
Erin, sorry, before you return to your slides, I'll just interrupt a little bit further. We're going to just put up a quick poll, if that's okay. Is that all right?
Please, yeah.
Okay, great. Thanks. If you could all fill out this quick poll, it'll take seconds, and then Erin can continue on. This is really helpful for us to know who's here on the call, who we're reaching, who we're missing, things like that. Thank you.
I have a bias.
Yeah.
But I'm filling it out.
I have a question.
Mhm.
What do you mean by, are you a member of a community of practice? What does that mean?
So the people hosting this today
Okay.
is the National Safer Supply Community of Practice.
Okay. Okay. got
So
it.
I'm not sure how you heard about this, but if you're a member of the community of practice, and I'm looking at your name and or at the name on your screen, and
Yeah.
your name looks familiar, I'm pretty sure you're a
Bloom
member.
Clinic. Yeah. Thank you very much.
And I'm looking at the comments here, and it's such a good point. Like, nurses have egos about this stuff. It's not good. I would definitely, I don't know. This is why I think it's always good to have a pal with you, because I feel like it helps. Like, nurses won't try to like prove that, like, oh, I can do it, when there's somebody else in addition watching. And yeah, I'm just validating and amplifying Katie's comment. Yeah.
Yeah, usually, especially in standardization sites, I could hit clients better than any nurse can, and it's just through like knowing where it would be easier on someone and where it wouldn't be. Right?
Mhm.
But I'm not anything close to a nurse.
Well, and what does that mean? What's a nurse?
What's a nurse?
But I did want to get back to some practical stuff around wound care, because I know folks are doing dressing changes. So here, some cleansing do's. The cleansing of a wound is definitely important. And the most common thing that gets used is sterile water, which is I guess the photo on the right. And they tend to come in kind of bigger packages. The nice thing about sterile water, not sterile water, normal saline, which is the picture on the right, and is the most common thing that's used in kind of like a healthcare setting. Because it has that salt component to it, the salt sort of acts as a surfactant, they call it, which means it helps to like dislodge some of the gunk that's in the wound bed that doesn't need to be there. But normal saline isn't always accessible. It's usually locked up in, the cupboards, the nursing cupboards. So if a nurse is being stingy about handing them out, or you just don't have access to them, the sterile water that you get in the injection kits is totally fine as well. And it's always good, like in this picture is actually a really good example of like, put the gauze on the wound and then wet the gauze from above, and then let that sit on the wound for a bit, like 5 minutes, to give like a really good clean. You don't have to don't wipe the wound, just let the normal saline or the sterile water do its job. And for most wounds, unless it's like a fresh surgical wound, if you don't have anything else, tap water is also totally fine. But what I would say is there are some cleansing don'ts. I think it makes sense that people want to use alcohol swabs to clean wounds, because you think, okay, well, the alcohol kills bacteria. And that's true, but the problem with the alcohol is that it is cytotoxic. And what that means is that it's going to kill any kind of like new growth, like new skin that's trying to grow. It will kill it. So, and it'll really dry out the wound bed. And both of those things will actually slow wound healing. And that's also true of hydrogen peroxide. So hydrogen peroxide is a really good cleanser for like a fresh minor wound. You get a paper cut or something and it's bleeding. You just want to clean it out to get the bacteria out. Sure, use hydrogen peroxide. But if it's a wound that's established, hydrogen peroxide, again, it's going to kill whatever progress your own body is making towards healing. It's cytotoxic and it's going to not be the best option. And then for dressing a wound, and I'm going to see, ooh, and I'm just looking at the chat. Stephanie, I want to go back to your question, so somebody please remind me. So for dressing a wound, I don't know if this is going to work, but Wounds Canada has published a step-by-step guide for like wound care at home is what they call it. But I'm going to stop my screen share and then I'm going to show you. But I don't want to show you this. I want to show you, no, I don't want to show you that either. Sorry. Now I'm not understanding Zoom. Okay. Screen share. I'm having a hard time opening it.
What's the name of it?
It's like the link that's on.
Is it
woundscanada.ca. This
best
one.
practice recommendation? Welcome to our most downloaded resource of all time.
Oh,
I put
sorry,
it in the chat.
I'm sorry, I'm bad with technology, but if you click on that link, it actually has like pictures and like step by step, like how to do a dressing change. Like it's super helpful. And really, again, like your goal is moisture balance and bacteria balance. So you've got your bacterial balance because you've cleansed the wound, and then maybe you have something you can put on it like iodine or one of those gauzes that has antimicrobial in it. Some people like polysporin, not to use a brand name, but I don't know. I'm kind of like, the amount of antimicrobial activity that it has is sort of like not worth the cost of the product. It's, I don't know, but it will keep the wound, you know, moist. So if the wound's really dry, sure, it'll help keep it moist. And you want to be careful to make sure that if your wound has a lot of exudate and you're putting gauze on that wound, what's going to happen is that like exudate is going to dry to the gauze. And then when you take the dressing off, it's going to be like that scene from the 40-Year-Old Virgin where he gets waxed. Like it's going to be like that, but you're like pulling off the tissue that's at the top of the wound. So you want to make sure that whatever you're putting on it, like that wound bed can stay moist. So dry gauze with a lot of exudate, that's not going to go well. There are versions of gauze that you can get that won't do that. They're called non-stick gauze. So you can ask a friendly local nurse for that. But that can actually be a lot better in terms of you know, the ouch factor. And also it for healing, right? Because whatever healing the wound is doing, you don't want to disrupt it by like tearing it off. You want to make sure that you're absorbing exudate. So often people will use those abdominal pads. They're kind of like white like this. They have a blue line in the middle. Those are fairly good absorbers. There's some really expensive absorbent dressings. So again, find your local friendly nurse if you need that. But the idea is you don't want too much moisture on the wound, because then what ends up happening is you get maceration where the skin is too wet. And it kind of has that, like when you've been in the bathtub for too long kind of effect, where your skin gets kind of like wrinkly and not so strong. So you want to manage exudate, and you also don't want your wound to be too dry. Oh, there's Sunny on his phone outside. And also being mindful that people are allergic to different tapes and adhesives. So always ask someone, like, have you had an allergic reaction to a tape or adhesive before? Because people will know if they have. And then you want to find options that are going to be really gentle. You want to secure the dressing to minimize damage to the dressing. And sometimes that actually is a big thing, especially if somebody is living in an environment that is not so clean. Helping to, like wrapping it with that, like that cling, that wrap gauze, or getting some Tubi grip from, again, a friendly nurse or something, just to increase the chances that that dressing is going to stay in place and stay clean, just so you minimize the risk of introducing new bacteria. And it's important for dressings to be changed when they get soiled. And you want to cover your dressing, but you don't want to occlude. So what I mean by that is if a wound is infected, you don't want to put, I'm sure everybody's seen that, like, it's a dressing that kind of looks like plastic. Have we all seen this? I don't know. I hope people are nodding their heads. I can't see everybody. I hope people are nodding their heads. But if you think about it, like, it's like saran wrap. If you put that on top of something that's infected, then that infection's just like staying there, and it, there's no breathing happening. So you don't want to occlude a wet wound either. So all of this, I hope you're getting the point about the moisture balance. It's so important. You want to manage your exudate, and you don't want to dry out your wound. And a good example of this, so that kind of dressing that I was just talking about, we can see it right here. It's that one. So this is someone who's had an abscess drained. And so abscesses, sometimes they require oral antibiotics, but they don't always. Because what's happening with an abscess is actually your body's immune system is already kind of like protecting the rest of you by holding that infection in one spot. We say it's loculated. So sometimes with an abscess, like if it's an early abscess, like you absolutely do the warm compress, that works. But if it's getting to the point where, it was tense, it was really painful for this person, they went and had an IND, an incision and drainage for it. And there was a lot of gunk coming out of it, as you can imagine, based on these pictures. But then they put this plastic dressing on top, and that plastic dressing is occlusive. So it was just like leaving all of the pus and gunk underneath it to kind of like stew and get more pussy. So that wouldn't have been my first choice of a dressing, but I think often in emerge departments, like the wound care capacity isn't that high. That's not like their specialty. So sometimes you'll see this coming out of an emerge, but if you were helping someone in the community, you might be like, dude, that's like too occlusive. We need to put something that's going to absorb the exudate better. I'm wondering if there's anything else I wanted to say about this particular.
I had a comment on this one.
Mhm.
The way me and Erin met was sorry, I'm gonna mute it while this. All right. Yeah, wow,
You're in a dynamic setting.
I know, right? The way me and Erin met was because I had a wound infection, which was caused by MRSA, and it wasn't from an injection site, like we were saying. Like, not all wounds and not all things are from drug use. Um, so yeah, so I had a little pimple-sized thing on my elbow. I ended up popping it. A day later, my arm was the size of a baseball bat. And South Riverdale directed me to Erin, the wounds care specialist at South Riverdale. Sorry, I'm gonna keep her in. Yeah, so I saw her after 7 days, but after taking the antibiotics and everything, and yeah, like my arm looked way worse than that, right? But because of the way because I was in a harm reduction community, the nurses were harm reduction friendly, and they understood the differences between like a drug wound and a wound that is caused by bacteria. I was able to battle that and have my arm better within a week. But that was my first encounter with Erin.
Yeah, I remember that.
Yeah, I was scared of her then.
I think, yeah, and I've seen lots of people like really do a successful job of an incision and drainage of their own abscess. Like that's a reality that happens. And again, if you have like, sterile needles, that helps, right? So people will do that. And then may need support with supplies for managing the wound afterwards.
Yeah.
I'm not like opposed to that option. And I think sometimes if an abscess is close to a major vein or artery, like it depends. It depends where the abscess is, how much you might like need to go to emerge to get it managed, because some abscesses, if they're close to like a major vein or artery, they'll actually want to do an ultrasound to make sure that they're not damaging. And sometimes even like a primary care clinic or like primary care doctors and nurse practitioners like won't want to touch those abscesses if it seems like it's in a risky spot. So what the hospitals will do is again like do an ultrasound, so they make sure that they're not like rupturing anything vital during the incision and drainage. But thank you for sharing that story, Sunny.
No worries. No worries.
The beginning of our journey together.
I was gone for too long, so I felt like I need to break the ice again.
And I think we just kind of wanted to close out here with just going back to those ways of supporting people with wounds. And I think this is stuff that we do in harm reduction communities anyways. We do a lot of this stuff. We provide support and reminders with dressing changes. And I always think like who is a person's friends and chosen family and community or family or whatever, and involving people in their care, with their consent. But like if someone needs, a dressing change every other day, dressing frequency is another thing. Don't let me forget to go back to that. But like maybe you need to get like the person's partner involved to help with those reminders, or put that pressure on about like, okay, but you need to get this changed. It's been 3 days. Like get community involved, get people's support systems involved. Just like even have them do the dressing changes if it's going to be something that they can't come to your clinic or your space for. But like involving people's communities, their chosen people in the care plan is really important. Dressing frequency. I know like wounds can be very can cause people a lot of anxiety, right? Especially depending on how big they are or where they are. Like it might be a source of anxiety, and you know, you can fixate on it. And sometimes people want to change the dressing a lot, but changing a dressing too frequently actually will slow the healing process, because sometimes your skin just needs time to, like, if you've got the right dressing on it and you've cleansed it right, like it just needs time to do its thing, you know, it just needs time to be under the dressing and to do its healing. But going back to sort of my original point, I think we need to be more liberal with like providing people with supplies. I'm not sure why some dressing supplies are really, really expensive. I have personally not ever been given a hard time about our supply budget. So I think like if you can be giving out supplies to people, I think that's great. And I know, where was I? I was at the CTS in Guelph, and they had like abscess care kits that people could grab if they were also grabbing like an injection kit. And I thought that was brilliant. Like it just had like a normal saline in it, like a couple types of gauze, some medical tape. You know, like give people supplies so that they're not tied to you for their wound care. I think providing accompaniments to medical appointments is so important. And I wish we were all like funded and staffed well enough that we could do it all the time. But I think as much as we can do that, it's really important. And then always monitoring for signs and symptoms of systemic infection. So things like fevers, chills, lethargy, all of those kinds of things can be a sign that like things are going in the wrong direction, and you need to kind of escalate care or escalate help for someone. And then I think the warm referral, like Sunny was talking about with his wound, and then he got like a warm referral to me, and now we're buds, like that all went well. But like being able to recommend a trusted healthcare provider, because some healthcare providers really suck and we don't want to be sending people to them because we don't know how they're going to be treated. So as much as we can, like doing those warm referrals, like if someone needs to see someone with more expertise or a more specialized knowledge, like who are those people that we can send folks to make sure that they get the care that they need and they get treated the way they should be treated. So that's kind of my spiel on that. Do you have anything to add to that, Sunny? You coming off mute?
Hello?
Yeah.
Yeah, no, I definitely believe that wound care is one of the most important things in harm reduction. Because a lot of our people face a lot of health complications, and I'm sorry you could only see half my face, but yeah, this is a ongoing problem that we face, and it can only stop by advocacy and by us at the front lines, like taking notice and like making healthcare accessible to our clients, right? Our clients are not like they're stigmatized by society. They are afraid of authority. They're afraid of hospitals. So, like, making it easier for them to access that healthcare is extremely important, and adhering to their needs and not complying with our mandates is the best way Erin could have put it. Like, yeah, so yeah, I learned a lot of my so I learned a lot of my healthcare wound care from Erin, and it was never I'm a nurse, you're a overdose response worker, you gotta do this. It was always a mutual relationship that like there was never hierarchy in it. There was just there's these people that need help, and we gotta help them in whatever way we can, right? So if Erin's good at wound care stuff, and I'm good at like having rapport with some people, and like like combining the two like really helps like with how it kind of come back to the site and are more comfortable with Erin, the other staff, etc. Right? So yeah, I hope this whole presentation it was just a drip in the water or the ocean, but it got the gist of what we're trying to say.
Yes, I really like what you said, Sunny, because I think like that's what harm reduction is about, and that's what community care should be about. Is like we are in community together, and we're taking care of community together, and we need to support each other and do that knowledge exchange. I've learned so much from you. Yeah, this is what we do, right? This is what we do in harm reduction. So just to close out, tools and resources if you want more. So I think we already talked, Rebecca already put the link in there for you folks. The Wounds Canada Care at Home series. Wounds Canada is pretty cool. I used to work for them when I was like 20 years old, many years ago. They're a pretty cool organization. That's where my love of wounds came from. But they have the Care at Home series that's really cool, so I recommend checking it out. And also the introductory guide for assessing and understanding common wounds in people who use drugs that came out of BC, and that was, I think, Alex Dunn and Tim Gauthier. It's a really good resource as well for identifying common skin and wounds stuff that we see on a regular basis. And I think also just like looking at our local resources and referrals, like drop-ins, injection sites, safe supply nurses, and people's friends and family. Like it takes all of us working together to support people's best health, best lives. So I don't know, for folks who haven't seen it, that's just like an image of that document I was talking about, and you can Google it and it comes up. And then the Wounds Canada website there.
Is there a good thing on Wounds Canada there about abscesses? Johnny's just asked in the chat about better practices. What are some of the better practices for abscesses other than heading to a clinic? What might folks be looking for as a sign that this cannot be treated with first aid peer support? Would that be a good resource? And if you have an
No. So I love Wounds Canada, but they're still kind of at the beginning of figuring out what harm reduction is. I think with abscesses, so going back to that kind of nerds and stonies thing that I talked about earlier in the presentation, it's like looking for those signs of deeper infection. Those are your red flags that yes, you do need to go to a clinic, you need to get it drained professionally. And then that's kind of, the line, like if there's spreading redness or the skin is tight, taut, shiny, or there's streaking, those are all signs that like infection is getting deeper, and it needs management. And I did work with somebody who actually had an abscess that was the result of kind of like a missed shot, but the abscess developed in the supraclavicular space, so just above the clavicle, and required a pretty lengthy hospital admission actually to have that adequately drained, just because of the location of it and like the kind of vital anatomy that was around it. So that's something else I always think about, like think about where is it? Is it near vital anatomy? And is the wound near a joint? And is that joint really swollen and hot and painful and decreased range of motion? Like all of those things are kind of where you start to think like, okay, these are some red flags that that we need to go, you know, to emerge or to a clinic or something to get it looked at. I hope that answers your question.
Thanks so much, Erin. I'd really just I want to also, Sunny, you're saying about how this is just barely scratched the surface. And we have comments in the chat who are saying like, yeah, I'd love to learn more. And just people who are so grateful for your time today and for you and Erin being here and sharing your knowledge and experience. It's been really, really valuable. Maybe we can have you back. We were to finish at 4:30. It's 4:40. It's up to, I'm not sure if Erin and Sunny are able to hang on a few more minutes if people have some other questions. There is one question in the chat that might be helpful to address around any legal ramifications, but I'm not sure. Do you have a couple more minutes, Erin, Sunny? 5 more minutes?
Mm-hmm.
Yeah. I keep changing locations, but I have all the time.
Okay.
Oh yeah, somebody's asking if you have any, is there any legal ramification to helping up here?
To drain an abscess?
Just
Is that the
with,
question?
I think just with wound care in general.
I don't believe so.
I mentioned in the way of like if you heal someone's or drain someone's wound a few times or something like that, for example, and then they would end up like with a worse infection or end up in a worse position because of other complications because of the infection like spread to their body, can like then they end up in the hospital in like a worse position. Can you get charged with something of like, you know, neglect or not bringing them to the hospital first, or let's say something like that?
Well,
Sorry, thank you.
I don't know specifically. I probably Erin does, but I know that if you're not medically licensed to perform something, you should not. If at all you're thinking that a doctor should be doing this, that means a doctor should be doing it, right? Wrapping a wound is much different than slicing an abscess and draining it, right?
Mm-hmm.
So yeah, like just have that as a guideline and go from there. But I can't attest to what charges or whatever.
Yeah, I would say the same thing. Like, I'm not a legal expert. I'm a registered nurse, so there's certain, yes, there's rules about what I can and can't do. So I can't, I think registered nurses can drain abscesses if they have a medical directive or something, whatever. But yeah, if it's a worker and as someone who's accessing a service, I think that's a different relationship than if it's like your personal friend, right? And like that's true for me and that's true for any worker. Like, I don't know if that makes sense, but like, yes, I think if it's someone who's using a service where you're employed, then yeah, I think you do have to think about what's prudent for you to do yourself, or whether it's, you know, a better idea to make a referral to someone who has more, I don't know, who would be better protected if there was a negative outcome. Because that's the thing too, like physicians have a lot more liability protection than nurses, and nurses have a lot more liability protection than overdose response workers, or I know some places call them peer workers, which we don't use that term so much where I work, but but like folks in overdose response worker positions have like almost no liability protection, right? So I think as teams, we also need to be protecting people, like protecting like our coworkers from being in positions that could go badly for them, if that makes sense.
Yeah. No, I hear that. Yeah, for sure.
Thank you very much. That was very helpful.
There's another question about first aid training for people who use drugs to deal more with vein and wound care. And another question also about crocodile and skin infections and sores. Can either of you address either of those questions? The first aid.
I would say everybody period should have a first aid kit at their place, whether they're a drug user or not, to address any issues that arise, whether it be drugs or not related. And use the supplies as best as you can and if it's serious, like have it so that it's good enough until you get to a hospital, right? Skin infections and that type of things again would be a doctor thing. I would just lead to the advocacy of like us having to give more access to healthcare to marginalized and it's like our people, you know. And I hate even saying marginalized and stuff like that. It's like our people.
I think a lot of places that do CPR training also will have like a first aid version of the course. And I think that mostly it's more focused on like traumatic injuries. Like what do you do if someone like comes to you with a stab wound, and you know, like teaching you how to like stop the bleeding, put pressure on the wound. I don't know if there's a lot of courses. That's an interesting question. But I think that's kind of the direction Wounds Canada is heading in terms of having more resources for folks who aren't necessarily registered health professionals to have some of that knowledge, skill, and training. And the crocodile, the only thing, my only exposure to that really was like through Vice documentary many years ago. I will say sometimes we do see what is it called, levamisole, associated skin eruptions. Like sometimes that gets cut into cocaine. I think it was more of a thing years ago.
Yeah.
So yeah, like there's weird shit gets put in the drugs, right? It gets cut into drugs. And some of that stuff can cause like dermatological eruptions for sure. And I think each situation is going to kind of be different about how you manage it, but just still with kind of those principles of, you know, is there spreading erythema, swelling, loss of function, like all of that kind of stuff, those red flags that would make you think we can't deal with this here, we need to escalate here.
Yeah. And it's for like us as workers to recognize it, because people might be too shy or too like in their world to be addressing those issues. So keeping an eye on your client and like making sure that like they're taking the proper care of themselves. So if you notice that something's different, that you can address it right away.
I think there's a hand up.
Yeah. Hi.
Do you guys have any tips on how to convince the person to go to the hospital if they just don't want to go? Because most of the time that I'm like helping someone with an abscess or a wound is because they don't want to go to the hospital or deal with any medical professional whatsoever. So I just can't bridge the gap of getting them to to convince them to go, like pretty much, or is there tips or anything like that you can give me?
I don't know if Erin wants to go, but I've had to deal with that many times, even before I was a worker. Like I remember one of my buddies having an abscess the size I've never seen that big of an abscess on someone's foot. It took him 2 weeks to accept going into the hospital, and even then he only stayed for 8 hours, right? So I have a new philosophy on life is that like everyone's body is autonomous and everyone has their own choices to their body, and the only thing you can do is tell them what you feel is best. But at the end of the day, they're gonna do what they want to do, and you can't like force them to do anything. You know, even if you know like their choice is wrong, like you're going like you all you can do is educate them. Yeah, all you can do is educate them and let them make their own choice at the end.
And like my part of that, as someone who is like entrenched in the healthcare system as a nurse, like my job and my role in that is to make the healthcare system less shitty for people so that it's easier for people to go seek healthcare when they need it.
So yeah, it's like a double whammy. It's like if a certain hospital was an amazing place to go to. They a friendly staff, nice service, all those things. And a good friend like yourself explaining to them, hey, listen, this is gonna affect your life by XYZ happening. Those two combined would make it easier for the person to access that healthcare, right? But yeah, it's hard. It's hard for someone to want to go somewhere where they know they're gonna be treated badly, not get the medicine or drugs that they need, right? So yeah, just that fear of not be like of being able to drug user, like makes people stay away from going to hospitals. Right.
Candace, your hand is up as well.
Yeah, if everybody can hear me okay, I was just going to mention with our team, we do a lot of advocacy work. So me as a peer, I will say like, hey man, like this is not looking so well. Do you want to come and see our nurse practitioner? And if that doesn't work, then we can always say like, hey, like I don't mind coming in with you to the hospital if that's the case. And it's astonishing what a second person in the room can actually do for that experience. But another thing that we've done with our team is we've actually got an outreach support system. So our nurse practitioners will come to clients, and then they'll do the assessment, and if they need to go to the hospital, then that's what they'll do. But our team's made tremendous leaps and bounds in this case because of all of the skin infections that we've been seeing this past year, I would say.
Yeah. It sounds like you're absolutely on the right track there, Candace. That's really good to hear.
Yeah, but I just want to add, like, having someone with them the entire time is important as well, because you might get them to the hospital, but they're just gonna wait for that moment that like it's late night and it's 8 days in. They're gonna try to escape, which they usually do. And it sucks because it's happened to a friend of mine where he's had multiple chances of getting the care he needed, but just couldn't stay in the hospital. And it was also because of COVID and not being able to visit, things like that, right? So hopefully after all that's over, like we're able to stay with our people and like see through it.
Yeah, that's it. It's yes, so true. And I'm just seeing Tiny Heron's comment. As a street outreach worker, I made my face and name very familiar in our local ERs, not only to the nursing staff, but case managers and ER attendings. This has been so helpful in regards to advocacy. Yes, 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 yes. So true, so true. Like the emerge departments like act different when they know people are watching, when they know that the person in front of them has a whole community of people there to support them. They act different. And yes, making these relationships is so important. Finding the good nurses and doctors who are going to be empathetic to your case. That's important, and like having them like ways to contact them if someone needs to go into emerge. Like these things are so important, and we want people to get the help that they need, and we want to do everything we can to make sure that it's an okay experience, right? Because we know that so many times it's not an okay experience, it's a traumatic experience. So that's our work as workers, is to try to make it less traumatic and maybe even make it okay. Yeah.
That's amazing. I'm going to call this webinar to a close. Big thanks to everyone on this call. I know everyone on this call is participating and working in contexts where it is about helping each other, and you know, trying to change the system to be a more welcoming place for people who use drugs, so that they are more comfortable accessing care. And in the meanwhile, you know, there's so many people filling in so many gaps, so many community members filling in so many gaps for each other, taking care of each other. And Erin and Sunny, big thanks to you both for your expertise, your time, and your commitment to this work. I think it, you know, you've shared some really valuable information and given us some tools and resources for us all to share. So big thanks to everybody. Yeah.
Thanks for having us.
Thank you.
Thank you.